So we did renal failure after diabetes.
So the patient we are working with, his name is Joseph Rodriguez. He's a 63-year-old Catholic, Hispanic, English second language male who lives with his wife, daughter, and 3 grandchildren. He works at GBS and has a yearly income below the national poverty line. During a routine checkup for his type 2 diabetes, he states that he smokes about a pack of cigarettes a day, struggles to control his heartburn, and that his typical blood sugar runs around 250 to 300 milligrams per deciliter. Lab tests were ordered and indicated microalbuminuria. Joseph was then instructed to make an appointment with an outpatient diabetes and endocrinology clinic for further testing. So right off the bat, we just see that there's a primary healthcare consideration that Joseph is an English second language and mostly Spanish speaking patient. And so with all of his interactions in healthcare, we have to meet his language need, which is going to probably include either a translator over the telephone or in person. But every interaction that he has with healthcare, that's a primary need so that we can tell him his full plan of care and that he fully understands his healthcare moving forward and all of those needs.
So now we have our first NCLEX question. So I'm going to read the question and then you can pause the video to read the answers and jot down what you think the answer is. So a patient's urine dipstick indicates a large amount of protein in the urine. The next action by the nurse should be to.
So a week later at the diabetes and endocrinology clinic, a GFR and ultrasound were ordered and indicated a GFR of 50 milliliters per minute and ultrasound results that were both consistent with stage 3 chronic kidney disease.
Okay, so the pathophysiology of chronic kidney disease is a significant reduction of functional nephron and repeated injury to the epithelial cells. There's an interstitial capillary loss and fibroblast proliferation. There's a progressive process of glomerular sclerosis and tubulointerstitial fibrosis. And it's associated with systemic disease such as diabetes, and it accounts for about 50% and hypertension as well. The National Kidney Foundation defines CKD as a GFR less than 60 mils per minute. Next slide. Again, it involves a progressive, irreversible loss of kidney function. And so there's different ways that the chronic kidney disease can develop, but with vascular and glomerular damage, there's a pronounced proteinuria and a nephrotic syndrome are more prominent. Hyperfiltration leads to an increased glomerular capillary permeability, which leads to proteinuria, which then again contributes to tubulointerstitial injury by accumulating in the interstitial space and activating complement proteins and other mediators in the cells, such as macrophages that promote inflammation and progressive fibrosis. Next slide. So angiotensin II promotes glomerular hypertension, hyperfiltration caused by arterial vasoconstriction. It also promotes the activity of inflammatory cells and growth factors that participate in interstitial fibrosis and scarring. And the change results from increased levels of creatinine, urea, potassium, and alterations in the salt-water balance. And it's, again, not apparent till about 25% of the normal surviving nephrons are unable to compensate. And diabetes and hypertension are the leading cause of CKD. 40% of type 2 diabetics develop diabetic nephropathy. And so diabetic nephropathy, it's basically, its pathophysiology is there's an increased level of glucose in the blood, and other factors that contribute to DN is increase in blood viscosity, increase in glomerular pressure, and other factors as well. The glomerulus are injured by protein denaturation, hyperglycemia with high renal blood flow, and intraglomerular hypertension. And this is a really good format that I've looked at, and it kind of leads you through that process of how diabetic nephropathy occurs, which then leads to a decreased GFR and then leads to renal failure. So some of the manifestations are increased difficulty with fluid retention, and they require diuretic therapy, metabolic disturbances such as significant elevations in BUN, which contributes to nausea, vomiting, fatigue, impaired thought process, and headaches, altered carbohydrate metabolism, so insensitivity to normal action of insulin, which leads to hyperglycemia. Hyperinsulinemia leads to increased production of triglycerides, LDLs, and HDLs. There's electrolyte and acid imbalances, anemia due to decreased production of the hormone erythropoietin by the kidneys. There's bleeding tendencies from the dysfunction caused by the impaired platelet aggregation. And also there's an increased risk for infection due to the changes in white blood cell count, cardiovascular disease, common cause of death as well. And there's other issues such as myocardial infarct, ischemic heart disease, peripheral and arterial disease, heart failure, GI disturbances such as anorexia, nausea, vomiting, as it progresses to end stage as well. Some of the neurologic are increased nitrogenous waste products, electrolyte imbalance, metabolic acidosis, and atrophy and demyelination of the nerve fibers. There's also mineral and bone disorders as well. Progressive deterioration of the kidney function leads to low levels of vitamin D and calcium.
Okay, so now that we've talked about a lot of the clinical manifestations of chronic kidney disease, here are the current standards of care. So first, they are going to classify your CKD based on your GFR. So with our guy, Joseph, he's at a 50 milliliters per minute. So it indicates that he has stage 3. And then now we're going to try and manage his hypertension. A lot of the times it's pharmacological therapy with like an ACE inhibitor like lisinopril or an angiotensin receptor blocker. And then we're also going to really want to manage his hyperglycemia with medication. Metformin is often the oral agent that's prescribed to control people's blood sugar. Sometimes also short-acting sulfonylureas like glyburide, and then insulin if indicated, if that's needed to help get tighter control. And then lifestyle management too. We really want him to watch his weight. We want him to control his protein in his diet, low sodium diet as well, decrease his alcohol intake, and he is a smoker, so we really want him to quit smoking because that can really impact the CKD.
And here's another NCLEX question. So a patient who is taking metformin to treat type 2 diabetes plans to undergo angiography using iodine-containing contrast dye. The healthcare professional should recognize that an interaction between metformin and the IV contrast dye can increase the patient's risk for which of the following? So the first medication that is commonly taken for type 2 diabetes is metformin. And so metformin is an anti-diabetic, and it is used to inhibit hepatic glucose productions and increase the sensitivity of peripheral tissue insulin. It is used to control diabetes, and if GFR is less than 30 milliliters, you should discontinue it because of the risk for lactic acidosis. The brand names are Glucophage, and the dosing, it is up to 2,000 milligrams a day, and if the GFR is between 30 to 45, you should try to avoid the use. And side effects are headache, nausea, vomiting, dizziness, weakness, diarrhea. And some drug interactions are just anything that causes lactic acidosis or increase hyperglycemia or increase the risk of going to hypoglycemia. And some herbal supplements you should not take with it are garlic and green tea. And some nursing considerations for metformin is a hypoglycemic reaction, which is sweating, dizziness, anxiety, and tremors. So to educate the patient on what it feels like to be hypoglycemic, and to monitor B12 levels because it can cause megaloblastic anemia. And don't give with radiologic contrast dye media because it could cause renal failure. And metformin should be discontinued temporarily for surgical procedures or when the patient is NPO. And the teaching should be signs of lactic acidosis, signs of hypoglycemia, hyperglycemia, and do not discontinue abruptly, and to take with meals. And the next medication that he's on is glyburide, is another anti-diabetic medication, and he's taking 5 milligrams twice a day. And it's commonly used with metformin and with patients with type 2 diabetes. And this causes functioning B cells in the pancreas to release insulin, thereby leading to a drop in blood glucose. This should be used in adjunct with diet and exercise changes to control type 2 diabetes. And so the max is 20 milligrams a day, and it can be given into single or divided doses. And some side effects are headache, weakness, hypoglycemia effects, and heartburn. And so the interactions are anything that increases the hypoglycemic effect or decreases the action, so decreases the glyburide, like MAOIs and NSAIDs and insulin. Also, don't take with garlic or green tea. And the nursing considerations are like the metformin, so hypo and hyperglycemic reactions, and to assess the blood glucose and A1C during treatment, and to get a CBC at baseline, and to report decreased blood count, and to teach to not discontinue abruptly, and the signs of hypo and hyperglycemia, and to eat food in the diet plan to prevent hypoglycemia, and to wear sunscreen because it can cause photosensitivity. So our third NCLEX question is, which information will the nurse include when teaching a 50-year-old patient who has type 2 diabetes about glyburide?
All right, so now we'd provide some education here, and basically would want to start with how he can slow his progression. And so the key things here is we'd want him to quit smoking and stop smoking, exercise and stay active, take his medications, monitor his blood glucose, and then his diet. And so for the diet part, this is a very important piece of the education, and this should be a piece that we also educate his family on, because his wife is probably the one that does prepare all his meals. So we want to let him know that he does have to restrict his salt and eat 1,500 milligrams or less daily. So you have to limit processed foods, eat fresh fruits and vegetables, lean beef, fresh turkey and chicken, and fresh fish are all good options here. And then don't take over-the-counter medications that contain sodium bicarbonate or sodium carbonate, which would be antacids, which we know he kind of suffers from heartburn, so he would be taking this. So we'd really want to include this in the teaching. We'd also tell him to eat less than 1,500 to 2,700 milligrams of potassium, because since the kidneys aren't working properly, potassium can't be filtered out of the kidneys. And so we'd want him to drain canned foods, avoid eating whole grain breads, wheat bran, granolas, milk, buttermilk, yogurt, nuts, seeds, peanut butter, dried beans, peas, fig cookies, chocolate, and molasses. And then we also want him to initially decrease his protein intake to 0.8 grams per kilogram per day. And we also want to decrease phosphorus intake, also because the kidneys can't excrete it, and then it can then cause issues in his bones. And so we'd want to tell him to not drink beer, any dark colas, chocolate drinks, and canned iced teas. And then we also tell him to not eat cheese, milk, ice cream, pudding, yogurt, liver, organ meats, oysters, sardines, beans, peas, bran cereal, nuts, and caramels. And then we'd also want to teach on some lifestyle changes he should make. And so we'd want to tell him to try not to wear himself out. And since he does work, this might be a little hard, but we want to really tell him that he needs to get plenty of rest and get more sleep at night. But also we do want him to move around and walk to prevent any blood clots or anything. Also weighing himself daily is a very good piece of it too, to know how much fluid he has, and also take meds as directed, and then control his diabetes. And then we want to also educate on when he should call his provider. And so he should call his provider when he experiences any chest pain, if he's having trouble eating or drinking, if he's having any weight loss of more than 2 pounds in a 24-hour period, or weight loss of more than 5 pounds in 7 days, if he's having little or no urine, trouble breathing, muscle aches, fever of 100.4 or higher, blood in urine or stool, blood discharge from nose, mouth, or ears, and then severe headaches, vomiting, swelling of the legs or ankles.
All right, so here's another little chart kind of going through the stages. And so right now he is about at a stage 3A chronic kidney disease. So this is moderate to mild loss of kidney function. And so now we mentioned he did have microalbuminuria at his primary care checkup. So what do we do for this? So routine screening for albumin in the urine is really important for patients that are considered high risk for kidney disease. So patients like that have diabetes, hypertension, vascular disease, autoimmune diseases, or just a low GFR rate in general. So we know that Joseph has diabetes and hypertension. So he's definitely a high-risk patient for kidney disease, as we've seen. The microalbuminuria part of it refers to albumin that's excreted, that it's above the normal range, but it's still below the level of detection for a total protein test in the urine. So what do we really do for this? I mean, an ACE inhibitor to delay the progression of CKD due to his hypertension. So we see that he's on lisinopril, and then that protein-controlled diet is really important, and that weight reduction, if possible, can help with a lot of the factors like preventing vascular disease and getting that blood pressure down to a normal range. So.
And here's the fourth NCLEX question. A 65-year-old male patient has glomerular filtration rate of 55 milliliters per minute. The patient has a history of uncontrolled hypertension and coronary artery disease. You're assessing the new medication orders received for this patient. Which medication ordered by the physician will help treat the patient's hypertension along with providing a protective mechanism to the kidneys? So, as Chelsea was saying, Joseph is on lisinopril, 25 milligrams once a day, and it's an ACE inhibitor, and they are used to slow the progression of the disease and even preserve renal functions by effectively reducing the systemic vascular resistance in patients, and it suppresses the RAS system and inhibits ACE, therefore preventing the conversion of angiotensin 1 to angiotensin 2. So prolonged hypertension can cause damage to the kidneys, so this is very important for kidney patients to be on a hypertension med, and lisinopril is the first one for diabetics and non-diabetics. So the dosing changes on each patient's GFR, and the maximum is 40 milligrams a day. And the big side effect is angioedema and dry hacking, non-productive cough, and the side effects of hyperkalemia and effects of hypotension. And the drug interactions are NSAIDs and any potassium supplements and any other hypertensive medications. So some nursing considerations is angioedema, which is swelling of the face, and anaphylaxis. And so if that happens, they will need to be taken off it right away. And the dry hacking cough, and to avoid potassium-sparing diuretics and potassium supplements, and to assess the CBCs to look at the neutrophils, and you need to teach your patient to do not discontinue abruptly and to rise slowly to prevent syncope, and then avoid increasing potassium in their diet, and to report the dry cough.
So some of the diagnostic and laboratory tests that can be done are early tests for microalbuminuria, dipstick of protein in urine, UA to detect red blood cells and white blood cells, protein, Cas, and glucose, ultrasounds of the kidney to detect obstruction incisive kidney, and serum creatinine, GFR ratio, and kidney biopsy for definitive diagnosis.
So at this point in Joseph's journey, the nursing diagnosis that we came up with was ineffective health maintenance related to complexity of therapeutic regimen of diabetes as evidenced by progression to stage 3 renal failure. We also decided powerlessness related to treatment regimen as evidenced by statements of fear and lack of resources in order to manage his disease.
All right, so here we are a few months later. Joseph is at a checkup at the diabetic and endocrinology clinic. His lab test results were as follows: a GFR of 25 milliliters per minute with elevated BUN and creatinine levels. Further testing indicated that Joseph had progressed to stage 4 kidney failure. When asked if he was compliant with his diet and medication regimen, to slow the progression of kidney failure, Joseph stated that due to his long work hours, lack of transportation, and inability to buy most of the food suggested on his diet plan, he was unable to comply with his previous discharge instructions from his clinic visit in January. He stated that he had been picking up more hours at work, resulting in less sleep, and can't seem to quit smoking. His heartburn had gotten worse, and he started taking Tums every day for the past 3 weeks to relieve the discomfort. Due to the progression of kidney failure, Joseph was scheduled for a procedure to create an AV fistula site, anticipating hemodialysis needs further down the road. So a patient consideration here is that as we deal with patients in the healthcare setting, we need to be able to meet them where they're at. And so all of the nutrition and patient education that followed that was pretty unrealistic for Joseph, especially with eliminating processed foods and buying lots of fresh fruits and vegetables and all of this stuff, because he is a low income patient. And so as we're evaluating patient needs, it needs to be really specific for each individual patient, so that we can actually allow them to comply with our education.
All right, and so since we are anticipating he'll need dialysis in the future, we just wanted to touch on the difference between peritoneal dialysis versus hemodialysis. So peritoneal dialysis is in the peritoneal space, and it uses the peritoneal membrane to filter the waste products, and this can be done at home. So some pros for this is it is a little less complicated. It's a portable system. There is training time, but it's pretty short. There is less cardiovascular stress, less highs and lows of uremia. And then, like I said, home dialysis is possible, so they can be a little more independent and have less diet restrictions. The cons for this is that there is an increased risk of infection, and I did see that there might be a risk of hyperglycemia, and he already has diabetes, so this might not be the best option. And then also the procedure may be difficult for some patients or caregivers to administer themselves, because they would need to problem solve if there was anything that would have gone wrong during it. And then hemodialysis, this needs a vascular access, and it is an artificial kidney basically that removes the fluid and the waste products. And so pros, it's that it's performed by trained professionals. There is opportunities for support and networking with other patients. There are shorter treatment durations and less days that you'd have to do it. And there is a rapid fluid removal. The cons is that they would need heparin therapy, and then they'd be fatigued right following the treatment, which would maybe cause him to not be able to return to work right after. And then an increase of hypotension and blood clots, and then an increased chance of blood infection. And so how to choose a treatment option. And so basically it just depends on the patient's goals, short and long-term goals. So if they do want to be more independent and feel that they can administer their own treatments, and that would be the best option for them. Also, their ability to train and learn how to perform their own dialysis, ability to stick to the regimen, because since they aren't monitored, they would have to do everything themselves. And then it's important to educate them on both, just to make sure they make the best option. But for our patient, it just seemed a little better for him to come into the clinic and have his dialysis be done by trained professionals.
So now that we have decided that we're going to go with that hemodialysis route for him, a big part of this is we want to get that AV fistula constructed if we are anticipating that we're going to have dialysis within the year. So an AV fistula is the preferred form of vascular access for hemodialysis, and it has less rates of complications and significantly higher patency rates for long-term dialysis. So they should ideally be referred when they know they're going to need it in the next year, because they require a couple months to mature and really be able to be used. So some of the patient education that goes with that is we need to educate him what this is going to be like. You need to routinely check for that thrill, and that he should know that no blood pressures or blood draws can be drawn on that arm. And then the AV fistula should just be regularly looked at by a physician to make sure they're still patent and still working. So this is just a picture of kind of how they work, and they're crazy to me, and I think they're so cool. So this is a really good option for him to have for hemodialysis.
Here's the next NCLEX question. A patient needing vascular access for hemodialysis asks the nurse, what's the difference are between AV fistula and a graft? The nurse explains that one advantage of the fistula is that it is
So some of the treatment options are reducing the risk factors for development of CVD by treatment of the hyperlipidemia, lifestyle and dietary changes, reducing the effects of hypertension on the kidneys as well as the heart, angiotensin converting enzyme inhibitors and angiotensin II receptor block that affect the angiotensin II. Also on this vasoconstriction and stimulating ADH release. Tight glucose management slows the progression of the vascular and heart disease. Limit intake of salt, carbs, and sugar. Protein restrictions is beneficial in slowing disease progression, controlling hyperphosphatemia. Protein restriction also limits phosphorus consumption. Phosphate binders to reduce phosphate absorption through the GI tract. No IV contrast or NSAIDs that could be potentially renal toxic drugs.
And another NCLEX question. The nurse in a dialysis clinic is reviewing the home medications of a patient with chronic kidney disease. Which medication reported by the patient indicates that the patient teaching is required?
So some of the variances in the disorder are, it affects about 38% of those 65 years and older. Between the ages of 45 to 64, there's 13%. And the ages between 18 to 44, it's about 7%. CKD is more common in women than it is in men. And it is more common in African American, about some 16% compared to whites, about 13%, Asians 12%, and it affects about 14% of the Hispanics. And African Americans are about 3 times more likely than whites to develop end-stage renal disease. And for every 3 non-Hispanics who develop end-stage renal disease, 4 Hispanics develop end-stage renal disease. Next slide. So socioeconomic disparities in chronic kidney disease. So we know that low socioeconomic status is 35% greater odds of developing microalbuminuria, about 78% greater odds of macroalbuminuria, and African Americans had an increased risk of CKD compared to whites, of which 10% was explained by poor access to healthcare and over 60% by demographic, socioeconomic, lifestyle, and clinical factors. Underinsured adults with non-dialysis dependent CKD were 40% less likely to be treated for hypertension and 55% less likely to receive the recommended therapy with angiotensin inhibitors compared to those with insurance coverage. Income below $15,000 was associated with a 50% increased risk of end-stage renal disease and a 3.5-fold increase in Black and white of developing of end-stage renal disease. So we know that low socioeconomic status was strongly associated with risk of end-stage renal disease, progression, and death.
All right, and so we need more patient education at this point. And like Chelsea mentioned, the AV fistula is kind of the main focus right now. So we obviously would want him to prepare for the procedure as directed. And then after the procedure, he'd obviously have to have some days off of work, which may be hard, but we want to make sure he knows that he needs to take care of this AV fistula so that it can work properly. And so we'd want him to keep his arm elevated as often as possible. Obviously, teach how to check the fistula, care for the incision, check for signs of infection, avoid any heavy lifting or strenuous activities, and then do arm exercises. And then also just living with the fistula, check the fistula often, and then make sure it's checked right before dialysis. Also the no blood draws and blood pressures, like Chelsea mentioned. Wash hands often and keep the site clean always. Never sleep on the arm with the fistula, and then don't wear any tight jewelry or watch on the fistula arm, and just protect it.
So at this point, our nursing diagnoses for Joseph are spiritual distress related to dealing with chronic illness as evidenced by patient verbalized questioning beliefs in religion, and also imbalanced nutrition, less than body requirements related to dietary restrictions as evidenced by patient statements of poor diet due to lack of resources.
All right, and so some patient needs related to the values. I just mentioned here a couple of values that Hispanic culture think are important. And so kindness is one of them that I saw. And basically this just means that they want to feel seen and welcomed, and they want to feel really cared for. This would mean that we would need cultural competent care. Bilingual posters and medical literature would really help. And then having Spanish handouts, especially when doing education. Also friendliness. So Hispanic culture people are always very close to family and value close relationships. And so it's very important for them to build that relationship with their provider and everybody who's caring for them, basically. And so it's important that we ask about their personal life and really get to know these patients. Also, respect is very important. So especially for older patients as well. So we would like to know how they would like to be addressed. And so we could just ask them. And then family is very important. And so they might always just have family members with them, and that's okay. And that should be respected, that they like that, those support people there with them. All right, and so I added some resources here because we did kind of set it up that we didn't give them the right kind of teaching, especially for Hispanic culture. So with diet, I would think it'd be pretty hard to follow a very strict diet regimen. So I kind of looked up some things that could help, especially in Hispanic culture, because they do like to eat a lot of tortillas and stuff like that. And beans is very something that they eat a lot. So I found this DaVita Kidney Care Diet and Nutrition. And basically they have free cookbooks that include recipes and list of foods that they could eat. Also, Kidney Today, the American Kidney Fund blog, they have little small food changes that Hispanic patients with diabetes and kidney disease could make to their daily food. And then also I did find some Spanish versions that talked about diet more in detail, because sometimes it's hard for us to really educate on the diet if we don't speak the language. And then also there was a diet guide for renal patients, and this was really cool. This was this whole big PDF basically that you could download, and it was all in Spanish, and it just talked about all the diet restrictions, and it gave them kind of like how to prep for meals, and gave them all these recipes that they could try. So I thought that would be very good for them, especially for the wife, because that's probably who is cooking all of his food. And then of course a dietitian, especially a cultural competent one, that could really help with his background and just the Hispanic culture in general. And then a couple other ones. There was an end-stage renal disease network program, and this had Spanish webinars that they could go to. And so this would just be a great place to find support people and just get more education, and it being in Spanish, so that would help them a lot. Also just support groups for the patients and the families. And as he progresses, he may not be able to care for himself in the future. So I found a couple resources that the family could utilize for them to get support and feel like they can give that care to him.
All right, so here we are in May of our case study year. Joseph was found at work severely confused and short of breath not long after he began seizing, when his manager called an ambulance. In the ED, labs were drawn showing a severe electrolyte imbalance and a GFR of 9 milliliters per minute, indicating stage 5 kidney failure. Joseph was admitted to the floor from the ED, where he was put on inpatient hemodialysis. After being monitored for several days and meeting regularly with specialists, Joseph was discharged with hemodialysis instructions for Monday, Wednesday, and Friday each week at a local dialysis clinic. So now at this point, as Joseph's life is really going to revolve around hemodialysis, we need to talk to him about the financial burden of getting all of this dialysis treatment. And so our job as nurses and connecting with social workers and all of these other resources in the hospital is going to be talking about Medicare and other financial aid to help Joseph, as he is going to be interacting with healthcare a lot these next few months.
All right, and so now we'd have to include more patient education, and obviously one of the biggest one would be just to update the diet. And so with dialysis, there is a need to increase calorie intake, and then also to increase protein intake, because during dialysis, the albumin is excreted, so we want to mention that. And then also just a little bit about hemodialysis and what he can expect. So with preparation, we just would like to tell him that he would need to get daily weights and just a weight right before. His blood pressure would be checked, pulse and temperature taken, and then his access site would be cleaned. Then 2 needles are inserted into the arm, one removes the blood, and the other returns it back into the body, the filtered one. And then some symptoms that he might experience during hemodialysis would include nausea and abdominal cramps. And if the symptoms are too uncomfortable, he can talk to his care team so they can adjust the speed of it. And then also blood pressure and pulse would be monitored throughout the whole procedure. And then finishing, the needles are removed, the dressing is applied to prevent bleeding, and then another weight is recorded. And again, we'd want to just mention that he might just feel a little tired. So if he was maybe planning on going back to work, he might need to take a couple hours to rest.
So now that he has progressed to stage 5 renal disease, our nursing diagnosis is death anxiety related to unknown outcome of the disease, as evidenced by lack of concentration and statements of feelings of impending doom.
All right, so now that he's regularly on hemodialysis, it's just normal for patients who have a GFR of less than 15 to be on dialysis 3 times a week. So we see that he has a GFR of 9, so he's definitely in need of this maintenance dialysis. So it's a minimum of 3 hours normally per session. So this is a lot of time he's going to be spending doing hemodialysis. And like Jenny said, that dietary changes, updating the dietary restrictions and needs that he has, and just continuing the management of that hypertension and his diabetes too. So, and then we've got some more current standards of care. So now he is in end-stage renal disease. He is there. He's in the last stage. So we're just going to treat any reversible causes of that renal failure that we can. Like we've been saying, managing that blood sugar, treating that hypertension, and continuing that healthy lifestyle change, because this is his life now. He's got to put his health first. So we also just want to slow the progression of the disease as much as we can. So more of that medication control and things like that. Treating the complications as they come up, adjusting his drugs when needed, and just identification of who is going to need the hemodialysis, which we already have said he does need it. And these are just some of the complications that come up. So we've already kind of talked about these, but that volume overload, hyperkalemia, acidosis, the mineral and bone disorders, hypertension, anemia, dyslipidemia, all of these things. So if you can see, I just put what we would do to kind of treat all of these complications as they arise. And then even further, malnutrition, that uremic bleeding, pericarditis, uremic neuropathy, and thyroid dysfunction. So there's a lot of scary stuff, but just really treating it as it comes up and doing our best for him. So.
Okay, so this should actually say May to November, but that's okay. For the next 8 months, Joseph regularly attended his 3 days a week hemodialysis appointments. Throughout the duration of these few months, Joseph was put on the kidney transplant list while keeping up with his hemodialysis appointments. Due to the severity of his end-stage renal disease, Joseph is unable to work, and his life mostly revolves around attending dialysis appointments as he awaits his spot on the transplant list. So our patient is really sick. Like Chelsea had said in the past slide, there's a lot that he's dealing with. And so right now it's really comforting care and getting him to those appointments, because that's really what's going to help him is, like Chelsea said, all the blood pressure, medications and all of those things, but also his kidneys are not working and not functioning how they need to. And so his life is really revolving around his dialysis appointments.
All right, so this is a super awesome little diagram of kind of just sums up what we've been talking about. So, and I love this little lady, so. So now some quality indicators for these hemodialysis centers. Since he's going to a hemodialysis clinic, this was passed in 2008, so it's a quality incentive program for these hemodialysis centers. So it promotes these higher quality standards of care than was previously seen in these outpatient centers. So it kind of changed the way that they paid Medicare and Medicaid services paid for the treatment of end-stage renal disease patients. So it just depends on now these quality care measures that they have to meet in order to get the payments. So, and on the next slide, we have some of these quality care measures. So if you see, there's different categories. So like clinical care, all these very specific things relating to dialysis. There's care coordination measures about coordinating that care and having those nurses in the dialysis centers really focusing on his care as a whole. And there's safety measures, things like med-rec, just their reporting and their infection rates, things like that. And then there's even some patient and family engagement measures, so through those HCAP surveys. So it's really cool to see that they're trying to make these as good as they can.
So the medication reconciliation process happens every time the patient transitions in care, so including changes in setting, service, practitioner, or level of care. And this is just a process of comparing a patient's medication orders to all the medications that the patient's been taking. And this is done to avoid med errors and all the dosing errors and drug interactions. So there's 5 simple steps of the medication reconciliation process. So the first one is to develop a list of the current medications, and then develop a list of the medications to be prescribed, and then compare the medications on the two lists, and then make clinical decisions based on the comparison, and then communicate the new list to the appropriate caregivers and to the patient.
This is just kind of what the dialysis clinics look like, and I just love this picture of this lady just snug as a little bug in a rug getting her dialysis.
So at this point, things are getting kind of scary for Joseph. So our nursing diagnosis is ineffective coping related to situational crisis, as evidenced by verbal admissions of inability to cope with stress and difficulty with organized information.
Okay. On Christmas Eve, Joseph receives a call from his nephrologist with the news that a kidney is available and Joseph is the candidate to receive it because he and the donor have the same blood type. With further assessment and cross-matching, it's determined that Joseph will in fact receive the kidney. It's a Christmas miracle.
All right, so now he got a kidney transplant. Yes. So what are we gonna do after that? So just routine follow-up, lab test. Care is often transferred to a transplant nephrologist for the first 6 months following that transplant, making sure that everything is being watched very carefully and we're monitoring for rejection. So we need him to be on that immunosuppressive therapy. Avoid rejection. We don't want to lose this good kidney. So these are just some of the agents that he would probably be put on, the immunosuppressive agents, and then just reducing the risk and managing infections like opportunistic infections and just minimizing complications associated with CVD because it's a really common complication in transplant patients. And so that's just a picture of the transplanted kidney.
All right, and so here are just some of the things we want to educate after he gets his kidney. And Chelsea touched on the immunosuppressant, so he will need this for life, and we want him to know that. And typically this is a short stay. He would have to be a strict I's and O's, and then obviously the diet again would be changing and usually according to his kidney function. We would also want to talk to him about the transplant rejection. And so there's 3 types. The hyperacute is minutes to hours after transplant, and then the acute is 6 months. And these 2 are both reversible with an increase of immunosuppressants. And then chronic occurs over the years. And unfortunately, this one isn't irreversible, so he would just have to be placed on a transplant list again. But with that, that's why it's important that he does really follow the diet and just really tries to focus on keeping healthy just so that this kidney can actually last. And then we'd also want to touch on transplant complications, and of course infection would be a big one, so we'd want to let them know that this is common within the first month, so really watch for that. Cardiovascular diseases with immunosuppressants, and which can increase the hypertension and dyslipidemia. Malignancies, recurrence of the renal disease, and then immunosuppressant side effects could include aseptic necrosis of the hip, knees, and other joints. And then again, him controlling his diabetes will be very important.
So because of his kidney transplant, our next nursing diagnosis is ineffective protection related to immunosuppressive therapy as evidenced by taking anti-rejection medications after his kidney transplant.
And now we get to end with 2 NCLEX questions. So which statement made by a 62-year-old patient with stage 5 chronic kidney disease indicates that the nurse's teaching about the management of CKD has been effective? And our last one is, which information will the nurse monitor in order to determine the effectiveness of prescribed calcium carbonate for a patient with CKD? And here are our references. And then our 2 nursing articles. And then we will post the answers with our PowerPoint to the NCLEX questions after you guys have thought about it and answered them.